Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Jenny Berkovich, board-certified pediatrician and director of education for JOMA. My guest today is Dr. Sharief Taraman. He is dual board-certified in neurology with special qualifications in child neurology from the American Board of Psychiatry and Neurology and clinical informatics from the American Board of Preventive Medicine. He is the chief executive officer at Cognoa and formerly serves as the chief medical officer leading the clinical trials that led to the FDA authorization of Cognoa's lead product, Canvas DX, the first and only FDA-authorized diagnostic device for autism in children 18 to 72 months with a concern for developmental delay. We had an incredible conversation about what it means to use AI in the diagnosis and early identification of autism, and really the potential that we have for AI in medicine. This episode is sponsored by Tovedo. Don't forget to use promo code JOMA10 on tovedo.com for an incredible, wholesome experience for videos for the whole family. I hope you enjoy the episode.
Hi, Dr. Taraman. Welcome.
Thank you for having me.
We were talking offline about how you first got on my radar. I heard you speak at a grand rounds, and I was fascinated by the work that you do and the type of things that you were using artificial intelligence for. So let's just get started. How did you even become interested in using AI for your field?
Yeah, great question. So I've always kind of been a techie person at heart. I actually started doing like technologically enabled things pre-medical school. My first real job was actually at Ford Motor Company, and I worked in like the computer science department. I was like a beta tester. This is back when I was in high school. And then ultimately, I think all through like my residency and medical school career, there was a lot of technological advancements happening. So people may not remember this, but at one point in medicine, we actually used to write everything down on paper. And so I'm of the generation that was in the transition from paper to electronic medical records. So I always kind of had a bent towards figuring out how to use technology to advance healthcare and make it better. And so interestingly enough, I was very fortunate post residency and fellowship training to join a hospital that had a really cool innovation program. And so that's the Sharon Disney Lund Medical Intelligence, it's a mouthful, Intelligence Information Investigation and Innovation Institute. So
that's a lot of eyes.
A lot of eyes. We call it MI4 Institute because that's too much to say. And one of my mentors / now friends there, after he saw Jeopardy win by the IBM Watson computer, decided that his MD, MPH, and MBA degrees weren't enough, and went to Stanford and actually got a master's in artificial intelligence. And his name's Anthony Chang. He's a pediatric cardiologist.
He's well known in the AI world. Yeah.
Yeah. So I was in this circle of people doing really cool stuff. And then ultimately met the founder of Cognoa, which is a company I'm now working for. And we were co-speaking on a panel on artificial intelligence in medicine. And I was sharing, these algorithms that I was working on to help like identify kids with neurologic disorders and not have them come back to the hospital. So we call it readmission, or figure out, in the case of COVID, for example, with Anthony using data to inform us, is it safer to get the COVID immunization if you have a congenital heart disease, knowing that there was some association with what we call myocarditis or inflammation around the heart, or is it more dangerous to get COVID native, get infected with COVID if you have congenital heart disease? And the cool thing about this is most of the time you have to run like a big clinical study and it takes months or years to get an answer. We were able to tap in and pull, I think tens of thousands of kids and look at kids who got COVID who were not immunized versus kids who got COVID who were immunized, who had congenital heart disease or got COVID, and what were the complications? And so you can answer these cool questions. So anyways, long story short, it's probably too long of an answer. I met the founder of Cognoa. I was like, this is a real clinical problem. I have way too many kids in our area that need evaluations for autism and neurodevelopmental disorders, and I can't hire enough specialists I'm one of like 1,500 pediatric neurologists in the country. So I'm like, we've got to figure out a technical AI approach to this. That's the only way we're going to help these families.
So I think like the very, I would say like beginner, people who are just beginning to be interested in the use of AI in medicine, I would probably put myself in that category. We sort of look at AI as a tool to like access, right, large amounts of studies, or to, like you were saying, like with the congenital heart disease and COVID vaccine, sort of make those types of decisions much faster than we were in the past. How else is it being used to, let's say, improve diagnostic accuracy, maybe specifically even in your field and what you're doing?
Yeah, so I think that the interesting thing with the diagnostics, specifically around AI-based diagnostics, is ability to actually, one, I think, increase efficiency. So, if I'm thinking about how long does it take for me to use research instruments that got repurposed for clinical care, right? A lot of these are very extensive, long, drawn out, maybe not the best for the family anyways, right? I mean, I think about it, right? You have families who are driving maybe a couple hours to get an evaluation, and then we're going to subject this kid to a 2-hour observation in a clinic, and they're not going to act the way they normally do. So can you use artificial intelligence to actually improve and make the process more efficient? And the answer is absolutely yes. The other one is that if you think about it, these things that we've sort of held up as potentially gold standards, and this, push for evidence-based medicine, which is very good, right? We should use evidence and base our practice on evidence. The reality, though, of many clinical trials is what? They exclude women. They exclude specific ethnic
Very
groups. They
biased, very
exclude
biased. Yeah.
minorities, right? And it's just, it's sort of the nature of the way we've conducted clinical trials historically, right? So there is a skew in our evidence. So even if the evidence is true, the question is it applicable to the population that we're involved with? So one of the things that, I was very adamant about and also successful about as the chief medical officer in my role at Cognoa was making sure that our training data was balanced for males versus females, which is very hard to do, by the way, in the neurodevelopmental space. If you look at most autism studies, the ratio of males to females is 4-to-1. So for every female, you're actually seeing 4 males. So of course your data is going to be skewed. The other thing is that we were able to recruit a population in our pivotal study that mirrored the US population in terms of race, ethnicity, and actually recruited a lower than the US national average socioeconomic status. And we were also very intentional about, for example, recruiting from the indigenous population through the Indian Health Services was one of our clinical trial sites. So in that way, one of the cool things about AI, if you do it right, is you can actually mitigate a lot of bias and I think essentially racism or ethnocentrism or sex biases that happen in traditional medicine with AI. Now, if you don't do it right, there is a risk for amplifying it, right? So whatever your existing
and that's been one of the criticisms, right, of AI, right? It's only as good as you make it. And there's, I think, some like early examples of asking even like Chat GPT questions and seeing some implicit bias because of the back end of that technology.
Oh, absolutely. But the really interesting thing is, and I think this was either out of Stanford or UCSF, I can't remember, but they actually were able to pick out biases that exist within our medical records. So again, if you train on the medical records, you may amplify bias, but guess what? You can actually use the AI to find bias in medical records.
That's fascinating. So let's say, it sounds like you're being very intentional about making sure that isn't the case or is accounted for in the way that you build your technology. But how does it actually work? In my experience, especially when we do screenings for autism or make that diagnosis. It tends to be state dependent, right? On what's accepted. And in some places it's enough for a general pediatrician to make that call. And I think most of us feel comfortable with being, doing that or making that diagnosis. Sometimes it's not a clear diagnosis. And in some states, it's not enough for a pediatrician to make that call. It needs to come from either a psychiatrist or a neurodevelopmental pediatrician, which I don't know how many of those are. Right.
750
Not
in the
many,
whole
right?
country. It's
Which is wild, right? And that's when we get into issues of access to care. So how can AI kind of bridge that for us?
Yeah, so the cool thing is, so the original work from Dennis Wall, Dr. Wall, who was at Harvard, now at Stanford, what he was able to do was collect from a Boston cohort of kids from diverse backgrounds, looking at some of the traditional research methods, so traditional instruments, and looking at what features were being extracted. And then the AI is actually really like advanced statistics, to be very frank. Like we don't like we can demystify it a little bit. So using basically advanced statistics, you can pick out what are maximally predictive features of autism versus other neurodevelopmental delays versus what neurotypical children present with. And based on that initial research, the question was, well, how do you collect that data the most efficiently? And the answer is we have these ubiquitous technology that we all probably are walking around with, which is a smartphone. And so you can have parents answer a question set. You can have parents upload home videos of their child. And by the way, these naturalistic videos are extremely powerful. And there's a whole plethora of research that shows if you bring a child into a clinical setting, their behavior is going to change, right? We know that there's this observer effect. And many times, and you probably had this experience too, the parents are like, my kid only does this thing in this situation, right?
Yeah.
I noticed there's a hand flapping or a spinning or a rocking behavior when the garbage truck goes by this specific thing happens. And you
We have to
can't
rely very
necessarily,
heavily
yeah,
on parental report for
exactly.
developmental screening, for autism screening, like the MChat, right? Which is our kind of like main screening tool that we use at 18 months and moving forward, is entirely on parental report. It's nothing that I'm observing myself objectively.
But best practices is what from the CDC and AAP is parental or caregiver report, observation of the child. But the beauty is you can use this from your home videos. And so we use home videos and then clinician report. And the reality is you're right. The American Academy of Pediatrics, which I'm heavily involved with, put out recent guidance, which included Canvas DX in their recommendations for primary care physicians to be able to use to make a diagnosis. And the thing is that the state and insurance restrictions, I understand why they do them, because we want to make sure that you're not, having unnecessary expense for children who maybe don't have autism. But in reality, those blockers are a detriment. And the insurance companies, if they actually realize what they're doing. So we looked at, so again, this power of big data, right? Because that's the thing that feeds AI. We looked at 9,000 claims data for children who had concern for developmental delay, who ultimately got an autism diagnosis. And it turns out the longer the insurance company waits, or the more blockers that they put, and the longer that a kid takes to get a diagnosis, the more they actually cost the system. So as much as
because intervention happens too late.
Exactly. So this Boston Children's study came out and they said, you know what? If you look at kids who got an early evaluation, early diagnosis of autism, nearly 40% of children who were evaluated early will no longer meet criteria by the time they're going into kindergarten and first grade. And the criteria that they lose is that their autism features are causing clinically significant impairment in functioning. So I like to equate this to, right, we can have obsessive compulsive traits, or you can have inattentiveness and hyperactivity, but that doesn't mean you have OCD, and it doesn't mean you have ADHD, right? Because if it doesn't impair your ability to function, it can actually be a superpower in some ways, right?
So I want to emphasize that a little bit, because I think that really speaks to the power and the necessity of early diagnosis and early intervention. This is going to make the difference between, a neurodiverse child thriving, right, in a typical school environment and in social society, or really struggling because we didn't get them tools and resources on time.
100%. And the other thing is too, is again, if you think about societal costs, right, the difference of early intervention is I can go to a mainstream classroom for more than 75% of the children if I have an early diagnosis versus being in a self-contained special education classroom, right? And we're all paying for that as a, you know, as a cost. But also, again, that clinical outcomes is huge, right? If I can have a child in a regular classroom, that's way better for them than if they had to be in a special education classroom that's self-contained. And, you know, long term, we know even to like early diagnosis, there's about a third reduction in the occurrence of co-occurring conditions during adolescence. So if a child is diagnosed later, they're more likely to develop depression, anxiety, or have suicidality if they're neurodevelopmentally delayed, but identified late or treated late.
So I think we've made a strong case for the need for early intervention. What would you say to somebody who's a skeptic, right? Either a practitioner or a parent, maybe who has a child that warrants evaluation. They'll say, I know they need early intervention, but I feel much more comfortable having a person evaluate them, having a doctor, having a neurodevelopmental pediatrician. What is a computer program going to be able to determine?
Yeah, so great points. So the AI doesn't replace the physician or the clinician in any way, shape, or form. What it's doing is it's augmenting our abilities. Think about it like if you were concerned about your heart, you wouldn't have your doctor put their ear to your chest like we used to do back in the day before stethoscopes were created. I mean, you have a stethoscope. You should use it because it's going to make your ability to hear the murmur or the heart condition way better. In the same way, what the AI is doing is it's allowing you as a pediatrician to have the confidence that a specialist has who has specialized training. And then for the specialist, it allows me to be more efficient and to be honest with you, spend more time with the family talking about what does this diagnosis mean and how are you going to treat it, right? If I'm spending 85% of my time figuring out if you have autism or what your neurodevelopmental disorder is, and then only 15% of my time talking to you about how we're going to treat it and focusing on treatment, that equation's messed up. That's backwards. We need to be spending 15-20% of our time on the diagnostic process, right? As long as we can get it right. So if you can do the same thing in a same accuracy, but in less time, that's more efficient. And we have to be efficient because we have a scarce resource, which is the specialists. So the two things that the AI does is, can it make your specialists more efficient so that they can focus on treatment, which is what we should be doing, and maybe the more complex cases? And then can we help the pediatricians be experts? So the AI allows you to level up your game, I think, as a pediatrician. And because the reality is, look, unless you're in like concierge practice, you have what, maybe 20-30 minutes with a patient, right?
At most.
Normally
At
autism
most.
at most. Normally autism evaluations take at minimum 90 minutes. Most of them are 3 hours. And then you have the report writing too, by the way, so the AI can help you document. So we produce an individualized, detailed developmental report for every child, because that also not only helps the clinician know, like, where do I invest my resources? And so it's not cookie cutter. Every child who gets autism needs X treatments, behavioral therapy. It really lets you look and say, oh, I understand, like, you know what, there is actually a pretty strong sensory component here. Maybe I should be thinking about occupational therapy. Maybe that's what's actually in the best interest of the child. And if you deal with, let's say, the sensory issues, then the behavioral therapy actually is more effective, or the speech therapy is more effective, right? Or maybe actually the issue is more communication, and you can apply all the behavioral therapy you want, but if you're not addressing the ability of the child to communicate, your behavioral therapy may not be as useful, right? So this tailored, individualized approach, the AI can help you as a clinician see that, which is also just harder to do if you don't have it available. So again, I think to the skeptics out there, it's not about replacing the doctors. It's about amplifying their abilities, scaling them up, upscaling them, being more efficient with our time, and then allowing us to actually do what we want to do in medicine, which is have a real relationship with patients. I didn't go into medicine because I love doing paperwork, right? You didn't become a doctor because you're like, oh, I want to do a bunch of paperwork, which is what has happened to us, right? And you wonder why the physician relationship broke down. So this is the opportunity, in my mind, where AI can actually bring back the humanistic part of medicine, which is I can spend time with you. I can have a real conversation with you because I'm not doing a data entry. I'm not spending 2 hours writing a report. So it makes the interactions more meaningful.
I like the analogy of it's like the stethoscope, right, for the exam. This is just like a piece to the exam to help you with diagnostic accuracy. Is the idea behind it that it's looking at a bunch of videos of how the patient is typically acting, and then based on, I guess, algorithms, right, that you and your colleagues design, makes either makes a diagnosis of autism or it doesn't, and then also breaks down, like you were saying, that whatever other pieces are important, whether it's a sensory component, whether it's right, noise sensitivity, etc.
Yeah, so the cool thing is that it's actually looking at about 64 behavioral features. And it's not just the videos, right? It is the parental questionnaire, it's the clinician questionnaire, and the videos. So it's these three independent inputs that are coming together. And then we're looking at these 64 behavioral features in 6 dimensions and relating every behavioral feature to every behavioral feature. So the beauty of the algorithm is that, and then we're comparing it against essentially a library and learnings of over 300,000 patients. So in any individual person's career, so as a clinician specialist, and of course, I wasn't just seeing autistic patients or neurodevelopmental patients. I was seeing kids with concussion and epilepsy and headache, right? So in my career, I don't know, practicing a full, healthy, full-time career, I might see, I don't know, 50,000 patients, maybe in my entire lifetime. We've trained this thing up on over 300,000 patients. So it's more than any clinician will see in their lifetime. And so it can pick out and say, okay, this pattern that I saw, I have X number of kids who have the same pattern. And the way that we did our reference standards, so our clinical accuracy, so when we say like what we call positive and negative predictive values. So if we say it's positive for autism, how do we know it's a true positive? Well, what we did is we had a specialist like myself with 5 years at least experience, board certified in developmental pediatrics or pediatric neurology or psychology, see these kids, not knowing what the device said, not knowing what Canvas DX said, and then say, does this child meet criteria for DSM-5 criteria for autism? And then because we know that actually, depending on who you see, you might get the answer that's not necessarily the right answer. And you know that this happens maybe somewhere between 20 and 30% of the time. If you go see a second physician specialist and you don't tell them what the first person said and say, is this autism or not? There's going to be
Those are some crazy margins. That's a
I know.
large margin of error for like a really significant diagnosis.
I know. Well, what happens is because there's a lot of overlap of what we call phenotype, which is like how you clinically present. And it's a spectrum disorder. So what's happening is it's not like everybody presents the same. There's so
Yeah.
many different presentations of autism. So what we did is we actually had a second independent blinded. So they don't know what Canvas DX said. They don't know what the first person said. Confirm the diagnosis. When they agree, we are like, okay, we know that this is a real autism or not a real autism.
Mm-hmm.
If they disagreed, we actually went to a third blinded independent person to basically serve as a consensus. And we actually played with looking at 5 and 7. If you had 5 or 7 people weigh in, does it change? And it turns out it doesn't. So if 2 out of 3 doctors, confirm the diagnosis, then it's a real case. Or dispel the diagnosis, it's a true positive or a true negative. That's how we do our reference standard, which is actually very different than a lot of other autism research studies. So again, if you go back to this evidence-based concept, right? The evidence is only as good as the evidence is. And what are you calling the gold standard? So we know, for example, you take some of these quote unquote gold standard research tools and you apply them in the primary care setting, their PPV and NPV go way down. They don't work because
even they're saying for like screening tools, like
no, I'm talking
MChat.
about diagnostic tools. But MChat, to be honest with you, if you don't do MChat follow up, the MChat itself is as good as almost as flipping a coin. I mean, I'm not trying to downplay MChat. It's important to screen, but you have to do MChat plus MChat follow up, because if you don't do the follow up, your predictive value goes down, and a lot of kids get missed.
What are the potential other uses beyond autism, right? So we talked a lot about like the importance of why we're focusing on this and the criticality of like a window of time where you want to get the diagnosis and get the intervention. But I feel like the scope is much larger. What's the
Oh,
potential?
absolutely. So yeah, so I mean, I think so initially, like in our roadmap, we were looking at all kinds of neurodevelopmental disorders or neurodevelopmental conditions. But to be frank, AI, the ability of it to support a general clinician is anytime there's a shortage is situation. So like I've seen some really good dermatological software as a medical device is the category within the FDA. And there's actually about almost, I think, they're almost to 1,000 FDA authorized AI devices now that are on the market. And so like we've used them in neuroimaging. So, I don't know if, or maybe your listeners don't know, but radiologists get really busy. And there's some really good studies that show if you even put like an elephant on the MRI scan, like right in the middle of like one of the sequences,
They won't
because they're
they
trying to,
they won't
they're
notice it
kind of going through, yeah, they kind of like overlook it. So the cool thing is some of the radiological AIs can point out, again, not replacing the doctor. I want to just be really
Yeah.
clear, but pointing out to the radiologist like, hey, look at this might be a stroke. Pay attention, right? And then now as a human, you go, oh yeah, wow, that's a good call. Thank goodness that AI helped me find that. Right. So I think that the opportunity for AI again is like helping us see stuff that we might forget or miss, looking for patterns that are sometimes hard for humans to see. The AI is like an assistant to that. Helping us with shortages, right? So think about even too like upscaling. I don't know if people know this, but again, not all radiologists, not all clinicians are made equally, right? And there's this concept of like tertiary care, right? So can you take a community radiologist who maybe doesn't see super rare, what we call zebras in medicine, and then help them so that if a zebra comes across their desk, they don't miss it, which is something that normally is seen at the tertiary care, freestanding children's hospital where you may not be getting care or that MRI is not done. So again, I think this is what we're seeing in this, sort of new revolution of artificial intelligence in medicine. And honestly, I do think it's going to revolutionize care. I think it's going to significantly improve our ability to detect and treat. It's going to help with a lot of the physician shortages, which have been a long-standing problem that we don't have a good solution for. And also this like disparity in care, right? I think that this starts helping democratize medicine. And, Eric Topol writes really good books about the democratization of medicine. If you haven't read those books, those would be good books to read. But the democratization of medicine is really important because we have these huge disparities, in healthcare based on, who you were born, what family you were born into. And that should not happen in the United States.
I like the idea of it helping with some disparities in health equity. What's a common or maybe a frequent myth that you hear about AI and people's hesitation to embrace it as it relates to healthcare?
I think you hit on one of them, which is the AI is going to replace me. So
Yeah.
that's not going to happen, right? But I can tell you 100%, the docs and the clinicians who embrace AI are going to replace the doctors who don't. I know that for sure. But the AI is not going to replace what you do. It's going to change what you do for sure, right? Like, so there may be some professions which ultimately change. But again, in my mind, in my experience of using AI, it has allowed me to be a more humanistic physician, right? So that scare, maybe on that myth is around, oh, well, this is going to end up like the EMRs. I think that's only if we let it. But this is where education of clinicians on artificial intelligence is so, so important, right? Which is why I do these grand rounds that you mentioned, because people need education. And honestly, just like they taught us how to use stethoscopes and reflex hammers in med school, they need to teach AI in med school, just like they taught statistics, right? You had to know the 2x2 table and what a p-value was. And in the same way, you need to understand probably, how to interpret if this AI is good and what is an ROC curve and does that actually apply to my patients and what was the data that this algorithm was trained on? Is it applicable to my population? And what is algorithmic drift, right? I mean, these are concepts that I'm kind of spewing out, but those are things that we need to have continuing medical education on / start teaching med school and residents on.
What are some of the, I guess, holes or gaps that still exist in AI? So obviously, right, again, if there's going to be bias on the back end, then the AI itself will be biased, and it's only as good as the data that you input, right, or the way that you program it. What are still kind of things that you think are things we'll solve for eventually, but are still some shortcomings?
Well, so one of the ones that people talk about a lot is they call it hallucinations, but it's actually not the right term. So
I just learned about this week, which and the person that was showing it to me like has examples where they like asked Chat GPT things and like it kind of like
Yes.
made stuff up, and it was fascinating.
Exactly. So, but again, if you understand how a large language model works, you understand why it does what it does. So large language models are a type of natural language processing, if you will, artificial intelligence. So it's looking at word associations essentially. So words that come together, how frequently they come together, and can you add strings? So I like to think about it or explain it to people who don't have a lot of AI background as sort of like a auto text on steroids. It's probably not a good example or a good way to phrase that, but whatever, it works. So it's like advanced auto completion or auto text. So of course it's going to do some associations that actually are not true potentially, and so it's more of like the proper neurologic term would be confabulation, because it's not hallucinating, and it thinks it's telling you the truth, but it's not. So confabulation is probably the better term. The other one that's actually, it's coming a long way fast, but it's not there yet, is what we call computer vision. So this is the computer or the AI being able to look at videos, for example, and extract information. We've actually gotten really good on sort of the opposite, which is similar to the large language models, which is I can give something now a text prompt and say, create a video of, you know, a physician in going on a spaceship to Mars, and it'll make a video of that. But the opposite of that, which is showing you a video of a clinician in Mars, like, and extracting the data, like the reverse is not as good. But it's getting there. And then I think to your point, again, the data structures are super important. And as much as we have lots of electronic medical records, there is still a decent amount of interoperability issues. So that's EMRs talking to EMRs, but the interoperability of the electronic medical record talking to another electronic medical record, and then also just misinformation in the electronic medical records. I think that's a huge problem. So I'll give you a good example. So I do a lot of work on preventative medicine, so drowning prevention, with our local American Academy of Pediatrics, so the Orange County chapter. I'm past president. So if we look at the drowning data, there's a lot of misinformation that comes in. So if you look at the electronic medical record, it'll be like, oh, the kid was at a pool and they drowned in the pool. And then what happens is like that narrative keeps repeating itself. And then it turns out it was actually not the pool. And you look at the coroner's report and the police report, and it turns out the kid was actually found in the bathtub. Right? Or example, I'm just saying, like, so sometimes.
So is it just like documentation error, and then
Well,
that just
it's
repeated?
almost like, yeah, well, that and bias. So you have to be careful. Like, there's a bunch of biases that happen in medicine too. So I teach about cognitive bias in like some of my courses that I teach, and one of them is like anchoring bias. So you get information as a clinician, and you're like, okay, this was, this is sickle cell, and then new information comes. But as clinicians and as humans,
you're committed. You're committed. So
yeah, we're
you're
like,
trying
oh
to
no,
make
it's
it
got to
fit
be,
into
yeah,
the sickle
exactly.
cell diagnosis. Yeah.
So in the same way, so there's all these biases that creep into medical records, whether that's an anchoring bias, whether that's a copy forward bias, right, or whatever, So I kind of forgot where I was going with this, but essentially, I think figuring out how to deal with the information that's being fed into the medical records, I think, is going to be really important. How do you reconcile people that get care in different places, right? So if you have a gap in your care, and the other actually big one too is there's a huge amount of what I call digital exhaust. So think about like your inpatient unit where you have a monitor that's monitoring a patient's heart rate. The nurse goes in and the nurse may document, once an hour, once a shift, what the heart rate was. But this monitor is actually tracking the heart rate and even heart rate variability. Right? That's a huge wealth of information that we're just sort of like digitally exhausting, right? It's just going out into the ether and we're not able to learn from it. So there is a big push in medicine to really connect all of the monitoring devices. And there's actually a specific one for pediatrics where Tim Chow, Dr. Chow is a former current Stanford professor, maybe too, is essentially creating a whole new infrastructure to connect um, all the devices in healthcare for children's hospitals together. So we currently have a node at Lucile Packard, Shriner Children's Hospital, and Children's Hospital of Orange County in California, and then a node in Bambino Gesù in Rome. So we've got 3 on the West Coast and Rome. So it's the proof of concept. And what we were able to do is actually, with Dr. Chang, transmit an ultrasound, a cardiac ultrasound, a cardiac echo in real time to all 4 sites and learn on the edge. So you can do learning in medicine or learning for AI without sharing the data, because this is important. So one of the things, especially for rare diseases, I've had cases where literally this is one child of 50 ever reported in the entire world cases. So how do you learn how to do, like, sometimes you can't share the data.
Right.
But what's cool is that if we connect all the children's hospitals in the entire world together, when that case comes up, it can say, well, you know what? There's a case that's similar to this, and whatever, this hospital overseas, you should talk to this doctor. Now, I won't share patient information, but it'll start connecting us in ways that we haven't been connected before. And do it in a way where you're not exposing patient data so you can keep patient privacy, but you can advance healthcare by learning from each other. So it's like a collaborative learning network, essentially.
That's wild. I feel like the gaps that we're going to be able to close in equity in what did you call it? Democratization.
Oh, yeah, the
Right?
democratization of medicine.
Yeah.
Well, and that's the reality. Like
It's very cool.
it would be beautiful. Both as a physician and as like a consumer of healthcare. Like if I had a rare disease, I'd love to know if there was someone
Yeah.
else in the world who had, and like right now, it's really hard to find those people. And
It
again,
is.
there's a lot of, so actually the most, I don't know if you know this is a fascinating concept that I actually learned from I have we have a summer internship program that we run every year where we bring in high school and college students and they spend 8 weeks with us learning about innovation and pediatric healthcare. So in one of those cohorts, I actually learned the most common, the most frequent, prevalent diagnosis is actually being undiagnosed.
In general, like in all of healthcare.
So if you look at all of healthcare,
Wow.
people who have no diagnosis, where it's like you can't figure out what the diagnosis, we don't know what it is actually the largest group. So individually, they
I
are
don't know what
super
that says
rare.
about our profession. That makes me like, it doesn't feel good, It doesn't feel
Well, but think about
comfortable.
it, like there's these, single point mutations that show up in healthcare and you get this sort of like very strange presentation or, whatever it may be, where literally you're like the only person in the world who has this thing at this given time. Right. So again, how do we, but the trick to this and the only way that we're going to figure that out is using data and data intelligence. So this is where the AI can be super helpful.
I want to wrap up with asking you about some resources or places where people can kind of go to learn more. When I heard you speak at Grand Rounds a few months ago, you had some like cool organizations. You also mentioned at the time, you said this is like my current like large language model go to, and you mentioned Perplexity, which I've been really enjoying since then. I'm curious
Isn't it
if
great?
that's,
It's a great resource.
I really like it because it cites what it says.
You still
And
got to go
so
check your references though.
that, yeah, but then I feel like it's easier to validate than like ChatGPT
Exactly.
or something like that. But yeah, where can people kind of, who either clinicians or maybe like families who feel like this might be a good resource for them, where can they go to learn more and general like AI organizations for medicine?
Yeah, great question. I don't, for the patient-focused education, I feel like there's a decent like educational resource through the American Medical Association, but I don't know if that's a true statement. So you'll have to fact check me on that one. I know for clinicians, there's a ton of really good resources. My most favorite is one called the American Board of Artificial Intelligence in Medicine, or ABAIM. It is a nonprofit group, and they do run both like beginner, novice, like introduction to AI for healthcare professionals. And again, that's everybody, because the reality is the nurses, the respiratory therapists, the social workers. If you work in healthcare, the CEO, the CFO, the CCO, whatever, all the people should know something about AI in healthcare, because the reality is again, I think if we allow this to happen the way electronic medical records happened and electronic health systems happened, we're going to be very sad.
It's going to happen
Because
to
it's
us.
frustrating.
It's going to happen
we
to
can't
us,
allow it to happen to
not
us.
with
We
us.
have to be we have to be part of the group that makes it happen properly, because it's coming. And this is a really important one too. And I don't know if there's anybody who's creating medical devices or working on software as a medical device. Please don't do that in a vacuum. So the way that this works best, and what we've done at Cognoa, is patients. So we have actually beta testers who are on the neurodivergent spectrum. We had focus groups where we brought in individuals who have autism, who have been diagnosed with autism. We included clinicians from various categories, right? Like you have to include everybody who's part of the thing that you're trying to solve, right? And you have to make sure that you have the diversity within that, because again, if you don't, you run this risk of creating a tool that only works for a very finite population. So as we are creating this, I think it's everybody's responsibility to understand it. You don't have to be an expert in it, but you should have a basic understanding of artificial intelligence, and you should have a basic understanding of what are the best practice principles to make equitable, transparent. And again, that explanation of the AI is super important. So if you look at what we've developed, I like to think that we've done best practices, right? So it's not just, is this autism or not? It actually will list out everything in the DSM-5 criteria for you and show you where we got the information from. And you can review the videos as a clinician so you can see what the parent uploaded, right? So that transparency to me is really, really important. And any device that doesn't have a transparent AI or explainable AI is not a device that I would personally use. So again, that going back to the large language model, the reason that I liked Perplexity as a tool is, to your point, it cites where it got the information from. So then I can go, okay, I understand why it's telling me the thing that it's telling me. I get where the word association came from, versus just random. I don't know, is it actually making this up? Is it real or not?
I love that. I want to thank you so much for your time and expertise. This has been fascinating. I'm sure lots more to come on the AI front. So I look forward to seeing how this all unfolds.
Thank you so much.
Thank you for listening to the JOMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@joma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.